writing, publishing in 1909. And what he said in his manuscript, he had no alternative to believe but that the treatment of a large number of the cases presently as inpatients are a waste of the resources of a children's hospital or ward. The results that he obtained in a wide range of pediatric surgeries as outpatients at a tenth of the cost were equally good. So what is going on here? Inertia. And our job to advance medical care for children, again, as well as the elderly, as well as everybody, is to overcome this inertia. It's not about patient safety. Now, one place that you can look for assistance to develop ambulatory surgery in the countries is through the International Association for Ambulatory Surgery, and we are a multinational and multidisciplinary group of enthusiasts from around the world. 20 full-member countries, and teaming around the world, from the Americas, North and South, Europe, India, China, Japan, Australia. And together we help each other and help other countries develop high-quality ambulatory surgery. And what I particularly would like to point is the teacher program. So we have gone to countries and set up multidisciplinary teams with teachers and participants providing education about ambulatory surgery concepts for the team that it takes to get it done. Administration and nursing and anesthesia and surgery. What happened from 1996 to 2006. And this is from Medicare, which is our national health insurance for patients over 65. So the data I'm showing you are for the elderly. And looking at procedures on the right, from 1996 to 2006, the number of ambulatory procedures doubled essentially, and there was essentially no growth in the minimal growth in the number of surgeries being done in hospitals. Overall, in the elderly, and this data set is from 2006, the last thing out, in comparison, is that as of then, 62% of surgery being done in the elderly go home the same day. And I would point out either. We have data, the same data set has information on where these ambulatory procedures are done. 57% are done in hospital, but even in the elderly, 42% are done in freestanding ambulatory surgery centers that provide high quality, safe, and patient-focused care. Now, how does this growth happen in the U.S.? I'd like to show you another data set. The first, this set starts in 1981. At that point, in the U.S., we were doing approximately 20 million procedures, 80% inpatient, 20% outpatient. Go 20 years later, the number of procedures has doubled, almost 40 million. But now, the percentage is flipped. It's 24% inpatient, 76% outpatient, and the number is higher than that now. It's somewhere in the 80% as we go into the present. What happened? In 1982 and 1983, what happened was the government started paying the same to surgeons and to hospitals, paying the same when they did their operations as inpatients or outpatients. The point that comes up again and again is what facilitates ambulatory surgery, better quality of care, which is simply payment parity, just giving it equal payment. Then the surgeons realize that the old ways they are doing it, there are new opportunities instead. So what about Australia? By 1996, they had a multi-specialty day surgery council. That data, the pink is the inpatient side, which is about 40% of the surgery now, growing at a rate of a little over 2% a year. The blue is their ambulatory surgery. It is now 60% of serving in all the public hospitals is also going home the same day. And parents, they would rather go home